At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I have the privilege of being the host for GLI Live. And today, in this October Liver Awareness Month, I am so excited to be able to bring you the most astounding global thought leader in liver cancer that I could imagine, speaking with Dr. Maria Reig, who is head of the Barcelona-Clinic Liver Cancer. I'm here to discuss breakthrough treatments in liver cancer and all things innovative. And so, Dr. Reig, welcome.
Hello, welcome, and thank you very much for the invitation, Dana. I'm very, very happy to be here to discuss and have some chat between each other and also with the audience. So thanks for the invitation.
Absolutely. Unfortunately, liver cancers are increasing around the world, but we're so grateful that the research and the screening and treatment options are also growing to keep pace, and that's what we'll talk about today. And a lot of them are led from your clinic and have been for the 35 years that we're celebrating in this anniversary of the Barcelona Clinic. And so tell us about the clinic and your unique approach to liver cancer care.
Yes, it is an honor to be part of the BCLC, that the BCLC is the home of the liver cancer. The BCLC started 35 years ago with two doctors that decided to work for patients with liver cancer. And it is special to say that the philosophy of the BCLC is centered in the patients. And maybe this is the reason why it's continued over the years. Because when you see the BCLC is focused in how the patient feel, how is the liver disease, and also the tumor burden. So at the very end, the clinical practice is put in a figure, and we decide the evolution of patient based on the characteristic of patients. Then we connected the characteristic of the patient with the best treatment that they could have. And the last part, and maybe it is the news for the new version, is the interaction between the doctors. And this is important thing. The philosophy of the BCLC is beyond the specialty. There are doctors that really work together for the patient. And it is not just a surgeon that is working in the same hospital as radiology and so on. We really work together. And I believe that this is the main difference between this classification that started with Dr. Bruce in 1999 than other that it also be part of the liver cancer management, but it is not exactly the same. So I believe that for those who are familiar with liver cancer knows what is the BCLC, but for others that maybe have another liver cancer such cholangiocarcinoma or meningoendothelioma, the BCLC is the classification for these patients who have hepatocellular carcinoma, and we can divide the patients in 5 groups, depends on the characteristics. So I believe that the best achievement of that is continue over the years, and we will have the new version in next month that we will present in our anniversary party. That is the scientific party of the future of liver cancer.
I think that is so important that you really do provide a home and approach for all patients, no matter how they've come to develop liver cancer. One of the driving reasons for GLI to create our Liver Cancers, Plural, Council is to really provide on the advocacy side, a similar place for patients, no matter if they come from, autoimmune space like I do, which caused my transplant 27
Yeah.
years ago, or from other causes. And so we're so grateful to have the involvement of the Cholangiocarcinoma Foundation, and the Fibromyalgia cancer, rare cancers, and really have people understand that it is liver cancer overall that we need to be, focused on, and make sure that no patient is left out. And so, your leadership on the clinical and research side has been, such a guide for us in our
Yeah,
approach.
this is very, very important, at least from my view, because when we talk about the screening, for example, we usually say a screening of hepatocellular carcinoma. And we prefer to talk about the screening of liver cancer because there are patients that are at risk of liver cancer due
Right.
to alcohol or hepatitis or autoimmune disease, despite of the fact that it's less frequent than the other. Or there are other patients that they don't know that they have liver disease.
Right.
And when the liver disease is identified, at that time, it's very easy to do an ultrasound. In this ultrasound, we could have the nodule, and after that, we need to do the diagnostic of the nodule. So I believe that for those who wants to work on that, it's essential to be inclusive, not only in the quality of the different region, also in the type of liver cancer that we are talking about. This is at least one of my goals for this month of liver cancer awareness.
Absolutely. Well, we certainly support that. And I think it points to a really important myth about liver disease and liver cancer that stands in the way of a lot of diagnosis and treatment, that all alcohol disease is caused by, all liver disease is caused by alcohol, and not by jet lag like me. That
Not for the alcohol.
is caused by alcohol. When we see top drivers being fatty liver disease and NASH and viral hepatitis, perhaps less so now that there are cures for hepatitis C and increased vaccination efforts for hepatitis B. But it really is a range of diseases, and a larger portion of populations in any country that are at risk of a liver disease. And I think that goes underappreciated. And so when we think of referrals in for liver cancer, they can come from primary care or endocrinology, gastroenterology, radiology, and really everyone across the system needs to be on the lookout for patients at risk of developing liver cancer.
Yes, maybe I would like to add to, I fully agree with your comment, but I would like to add that maybe the difference could be when we identify patients with liver disease, regardless of the etiology of that. Because sometimes this is the stigma that if you are alcoholic, you are at risk of liver cancer, but if you have another liver disease, you are less at risk. Up to now, we know that the patient because there are patients with liver disease, patients who have cirrhosis are at risk of liver cancer. But there are another underestimated group of patients that they consider or they don't know that they have liver disease. And this is a target group of population or citizen that we need to work on that. And that's why prevention of the factors such as alcohol, metabolic syndrome, or hepatitis is the primary care area that maybe we need to work together. And in this setting, then we need to work with the radiologists, because you could identify the people who could be at risk, but if you do not have someone, hepatologist or radiologist, who really know how the ultrasound was performed, the screening is not working. So my key message here is not only the prevention factors, is the combination of prevention, work together to do our best, to have the best ultrasound that we would have to identify the nodules, and then we can work in the diagnosis. But
I think that's fantastic. I think that's a really important point. So many patients have come to us saying that, oh, yes, there was when we look back, there was a note, sort of an incidental finding, perhaps on imaging, that wasn't followed up on. And so if there were more awareness amongst radiology that this is something to, see, to note, to pass on, and there were more communications and pickup, hopefully we would catch more patients earlier in the process when there's still the opportunity to take advantage of so many of the treatments that have been developed in just the past few years in particular.
Yeah, sure. And the other important point is, regardless of where you are living, you should have the option to visit for a doctor who are really involved in liver cancer disease. And I would like to say that because in some countries, the radiologists are performing the ultrasound. In other countries, have the hepatologists or they are oncologists. But I prefer to talk about physicians involved in liver cancer, because you could have different disciplines, but if you are really involved and you have the expertise for that, it's perfect. We don't need to see what is the specialties around the team. We need to work together for the aim of cure liver cancer, but the most important thing, to prevent it.
Right.
So I believe that we could work together, and this month is amazing.
How can how can physicians in rural areas, in countries where perhaps the healthcare system is not as advanced, connect with the expertise that you develop, for example, at your center?
This is a very good question, and sometimes I don't have the true answer for that, because the heterogeneity between the countries are very, very huge. But I believe that is the area that we could work with the associations, the associations of liver disease, association of patients that who develop a network between the centers that they are expert in the field and thus with less expertise. But it's not only the connection. Maybe the goal is to do network for improving the expertise in all of the areas. But it's also important to keep in mind that there are some areas that are less frequent than the others. Right. And for those areas that you are in a country that you have low incidence of this disease, maybe we need to work different as if you are in another area that is a very high incidence of the liver cancer. We know that the incidence is increasing around the world, and we know what are the factors, but at least for my point of view, we need to work in the strategy rather than improve the centers, because there are good centers in everywhere, but we need to work in a different strategy.
I love that concept of improving the strategies rather than improving the centers. And, we have been heartened by countries such as Malaysia, who has asked to adopt our Liver Cancer Council's model. And we hope to create those connections. And I think, to your point of, there have been countries where liver disease and liver cancer has been more prevalent for decades. But now that's shifting because of NASH prevalence and other drivers, where the liver health and approaches to liver disease have not been as high on the public health agenda for them. And we need to sort of reconstitute and refocus that for them. So I think this idea of focusing on the strategies based on rising prevalence is so sound. We look forward to working on.
Yes, indeed, the European Liver Disease Association is working on that. And it is on now the letter to sign to improve the awareness and also the interaction between the different countries focus on that. So I believe that we could have some very good for the next years.
Absolutely, and GLI signed on to that letter, so we were glad to see that and support that leadership. Let's focus on treatments for a little bit and give people an idea of, because it has been such an evolving area, and it's exciting to see an area of liver disease where there is a lot of research that is fruitful and making treatments available to patients. Certainly, as I've looked over the disease state, when we first started GLI. And then
Yeah.
in the past few years, there's so many more treatments available in liver cancer for patients. And so what are you most excited to be able to make available for your patients in immuno-oncology or other areas?
Yes, I believe that we have a lot of cancer, and we can say a lot of cancer because when I started in 2007, there were only one systemic therapy for patients with ATC and no one for patients with cholangio. And now we have several treatment for systemic therapy and also have immunotherapy. But before talking about that, that everybody knows the disadvantage, I'd like to take a minute for the other treatments such as liver transplantation that for decades were only for ATC. And now there are more and more data that some specific patient of the profile of patient with cholangiocarcinoma could be also be candidate for transplantation. So I believe that as a doctor, expert in that field, it's amazing for patients, but it's more responsibility for us. We need to work more and more together to interact between radiology surgeons and clinicians to identify the best treatment for each patient, obviously based on the characteristic, BCLC, and so on. Having said that, that is the point that I would like to emphasize. There are other treatments such as percutaneous treatment, local regional treatment, the role of radioembolization that is have a specific role in a specific group of patients, but without that, immuno-oncology changed the landscape of patients with advanced HCC. That are those patients who have less overall survival based on the prognosis. And now with the different schemes that we could have very good outcome, not only in terms of survival, also in side effects and so on. So in brief, I believe we are in a very exciting time. But again, we have a very, very high responsibility to select the best treatment for each patient. In the past, when we have only one options, we could decide based on the characteristic of patients. Now we need to use other tools to identify what is the best option for each patient. Because when you have treatment that improve overall survival, your goal is that. But we have more than one. It is another area for discussion, and the role of the patient is essential because sometimes you have patient that ask you, please decide on behalf of me. But you have other patients that you say, I want to know more about that. But it's more difficult to decide based on the on behalf of the patient because if the patient has some question and so on, it's easier to share the decision. So I believe that is a new era that we need to work together and try to identify tools to define what is the best option for each of them. But this is another thing that sometimes is not easy to manage. That is the option to have the treatment in the countries. For example, I'm in Spain, and there are not options for second-line treatment in our system. So we know the evidence. We need to share the evidence with patients, but sometimes we are not able to prescribe the treatment. And this situation, it is not the same in this country, in the United States, France, or other countries. So it's important to keep also these points in the clinical decision making.
Absolutely. You point to the reason why, GLI has made a strategic decision from the start to be involved in policy and access issues because, when I was looking at the landscape of the space, there was this wonderful innovation and research engine. But if patients don't have access to it, it might as well not have been invented. And so, I know I'm only alive today because I've, stayed one step behind innovation and always have been able to have access to the full range of options. And so as we talk to patients around the world who would be good candidates for treatments that are available, but not to them, to lift those barriers is really important work for us.
Sure.
How do you going back to the shared decision-making process, another area we talk about is how to make sure that patients have as many options available at the beginning of their process when they're newly diagnosed, and the instinct may be to start on a treatment, but that may preclude their engagement in clinical trials or their eligibility for other treatments down the road. And so how can we have the conversation with patients, when they're newly diagnosed and so anxious, that really sort of gives them a sense of the entire pathway or journey and the decisions that they may have to make over the course of their disease.
Yes, this is an essential point in the early phase of the visit that we have with the patients. We usually, at the BCLC, I share with you how do we work here in the BCLC. The first visit, we review all the information, and we also have the interview with the patient. At this visit, we know each other. We know what is the profile of the patient, how is their families, also the social environment and all of the things. And also we ask for a specific question as, how do you feel? This simple question could change the visit, because if the patient is very tired, there's not option for walking or whatever, it means that the patient is with more illness than others. In this first visit, we start the communication. And then after having all of the exams done, and we have the diagnosis and the staging, we explain according to the BCLC what is the best treatment that we can offer for them. But sometimes, for example, if a patient that is candidate for percutaneous treatment, but due to the location, it's not feasible to do that treatment, and we need to discuss and explain what is the probability of have a good result with that or not. And depends on the profile of the patient, you could share more and less details. Because sometimes if you give a lot of information, it is completely opposite that we want, that the patient feel afraid that they are not talking anymore. So the decision making, sharing the decision with the patient is a process that we can see as something that we need to work together, and it is not possible to do in only one visit. And this is the most important thing. Sometimes we need to take a week to explain, to ask questions, and to come back and continue with the questions, and also to talk with the family or the friends that are coming with the patient to understand what is the situation. But if you are in a specific situation that you have two options, we need to share why do we consider that the best option is this or this, instead of say, what do you prefer? Because this is not a job. Sometimes it's easier to say that, because you spend less time to do the treatment that the patient wants than to demonstrate what is the best things according to our knowledge. So I believe that we need to take more time to decide with the patient. And in the liver cancer field, there are not prompts that we could use to use at this stage. And we are at the hospital, we are working on that.
I think that that's very important. Having worked on patient-reported outcomes measures in other types of liver disease, I think it is so valuable, and the insight sometimes into what patients actually value, or the weights that they put on certain symptoms or side effects, is different from what physicians may think. And having that conversation, certainly at an individual level, but having that conversation across the field, across drug development, across care, is so important, I think, to finding something that is satisfactory from all sides, and not just perhaps in improving an outcome that frankly isn't as valuable. I know conversations with my own doctors about something that may have an impact ultimately on my longevity versus something that will make me more functional now or for the next few
Yeah.
years, my preference is in one direction, and other patients may have in another. But being able to have that conversation and find something that really resonate and works for me is, I think, such a valuable opportunity, and frankly builds a lot of trust with me and my care team, and helps us be able to make decisions, down the road again and again.
Yeah, yeah, yeah. We did in the hospital. We did evaluation of the
Hmm.
patient experience,
Yes.
and it was very useful to know how the patients perceive our work, because
Hmm.
sometimes we work with this specific duration and then the perception is completely different. We are very happy because they are confident with our work and they are happy. There
Hmm.
are areas for improvement for sure, but in general, they are confident with the doctor's
Right.
recommendations. And this is something that is very, very useful for patients, because if they trust in the doctor that they have, they could be the life easier. And my recommendation for those patients that don't trust in the doctors, don't
Hmm.
perceive that it's a bad time. I
Right.
suggest to consider to look for the doctor that you really trust,
Hmm.
because if not, you have the illness and you also have the conflict to know if you are follow or not, and you add more confoundings. So we usually say for the patient from the first visit that is our decision. We can share the decision, we can say, but we also give the opportunity to ask questions to other doctors. In general, they are here and we are the BCC, but at the very end, it's important to give the opportunity. If you give the opportunity, the other person could decide, as we decide when you have our problems.
Absolutely. Two supports for that decision-making process that we've discussed are nurses and peer mentors, like those that we train coming out of our Advanced Advocacy Academy, to have the support of patients who are just a little further down the road. And thankfully we have more and more of those in liver cancer with the free survival, and caregivers as well, who've been involved in the process, to who have more time to create a safe space for patients to deconstruct and digest some of what they've heard from the doctors, and figure out how to manage and move forward. So can you speak a little bit about the role of nurses or other
Yes.
supports for patients?
Yes, we have a very great team of nurses at the BCSC. We are very, very lucky for that. I believe that the role of nurses is key in the patient journey, because they are the part of the team that are really connected with all the physicians and also with the patients. When you are the physician that are follow the patient, you interact for only one or two patients, depends on the
Hmm.
discussion, but they have the input from everybody, because the nurse talk with the patient and the patient explain different
Hmm.
things that are not explained for doctors, and they are the person who coordinate all the patient care. They have also an educational program for patients with liver cancer, and they
Hmm.
are also the support for them with the phone call visits. That we have a program that we believe that we should integrate everything in the role of the nurses. So that's why for us is essential to have the nurses. And the other point that you mentioned, that is the time.
Hmm.
Sometimes we believe that the doctor have less time than the nurses, but now the nurses have more and more patients. And
Ah.
sometimes it is not only the time that we
Hmm.
spend in the visit, it's also the relationship that the society have with the nurses in
Hmm.
comparison to the doctors. For me, it's more social than the specific time. Sometimes
Hmm.
we spend a lot of time with the visit, but the question that the patient asks for the doctors, they're not exactly the same that the question that asks for the nurses.
Hmm.
And depend if here in the BCLC, sometimes the patient come to the doctor and then to the
Hmm.
nurses, and
Hmm.
other patients, the nurses and second to the doctors.
Hmm.
And if you invert the interaction, the question that we receive as a doctor is completely different than the nurses, because the nurses already mention us the
Hmm.
specific topics, and we can have different interaction with them.
Mhm.
So I believe, again, the multidisciplinary team, the real team, working together is essential for the communication in all of the directions.
I absolutely think that that's true. I've experienced that mentoring patients, and the question they have saved to ask me is different from the one that they ask the doctor or their nurse or their coordinator. And so I think all together we can get all the questions answered.
Sure.
Another thing before we wrap up, we recently did a webinar on a virtual tumor board that gave some transparency into how the different disciplines work together to create a care plan for a patient. Is that one of the things that virtual tumor boards and access to them can be more helpful in creating more equitable care moving forward for a broader swath of patients in different countries and settings?
Digital tumor board is a good initiative, but then the applicability in the real world work, it is more difficult. But again, for the implementation of that, because when you discuss the patient, it is not the same if you really visit the patient that if you are talking about a patient that another physician are explaining to you. Is better than is as consultant for the patient, but I strongly believe that we need to work to develop tumor board in specific centers rather than extrapolate the expert to the other center. You know what I mean? I prefer to work on improve the connection, the interaction between the doctors working at a local level than to expand the knowledge digitally.
I think that's fantastic. I do agree that building up the assets in local communities is so important because they do know the patients personally, their families, their circumstances, and it creates a virtuous cycle within the health of the entire community. So what does the future of liver cancer hold? What do you want to celebrate on the 40th and 50th anniversary of the Barcelona Center?
I hope I will celebrate it here. I hope. And my hope for 40th or 50th anniversary is to celebrate the prevention of liver cancer and also the diagnosis of liver cancer at early stages of the disease. So if we are able to achieve this goal, I will be retired very, very happy. But I hope that we also need to have more interactions between the different disciplines, and also the last but not least hope is work for all primary liver cancers and not just for one or the other. Rare liver tumors are also important, and we are also working on that direction with a network of meningoendothelioma, for example. So
those are fantastic goals for all of us to take forward for liver cancer awareness months and all year long until we achieve them. So Dr. Reig, thank you so much for our conversation today.
Thank you for the invitation.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.